Healthcare is too expensive. Employers are offsetting costs onto their employees. Who will make health benefits affordable for hardworking Americans and their families? You will. This is the Empowering Plans Podcast, a show dedicated to helping you once again emphasize the benefit in benefit plan. Now prepare to learn, plan, save, and protect with the FIA Group.
Hello, and welcome to another exciting edition of our Empowering Plans podcast. My name is Jen McCormick, and today I feel so lucky to have Jen Berman of MZQ sharing the hosting duties. So just real quick, Jen B is a leading expert in all things healthcare reform, and today she has agreed to join us to talk a little bit about mental health parity, which is a super important topic. Jen, thank you so much for being here.
Oh, my pleasure. Thanks for having me.
So I'll give a little bit of a background about why we're here, getting everyone up to speed. And then, of course, please jump in at any point. I'm sure that you'll have lots of exciting and interesting insight here about this topic, of course. But really, one of the reasons why this has become such an important and relevant hot topic in the industry is because of the Consolidated Appropriations Act. And that really, in my opinion, has sort of jump-started mental health parity enforcement. So quickly about this act, this was actually passed in part due to some of these rising mental health and substance use disorder benefits. And a lot of those had been aggravated by COVID-19, which many of us has touched upon, from being a parent to being an employee to working in a remote setting. This has had such a significant impact on so many of our lives. And the basis of this act actually puts the DOL enforcement mechanisms into play and moving more from that compliance assistance friendly model to more of a proactive enforcement model. And this is actually putting a lot of pressure on the plan sponsors and employers, administratively, compliance, logistically, financially, and they don't have a lot of time to make plans to prepare for this.
You know, it really is, Jen. And the provision of the CAA in particular that we're talking about actually requires the completion of an analysis of how a plan is complying law that's been in place for a long time. And they call it a congressionally mandated book report, which is kind of something new that we've really never seen in this space before. So, you know, people ask like, oh, well, who do I turn in my non-discrimination testing to? And I say, you know, you do non-discrimination testing to make sure that you're not violating the rules, not because there's an affirmative requirement that you complete the testing. You just have to do it in order to make sure you're compliant. Here, now we have an affirmative legal requirement to do the analysis to show that you're in compliance. It's kind of a very new concept.
Yeah, and you know, that's the thing that's interesting, is that everyone at this point is so concerned about the how, which we can get into in a little bit, but the new piece of this is the documentation. The parity piece isn't new. So that has been another concern, is that a lot of the provisions in the NQTLs, or those non-quantitative treatment limits, the pre-auth requirements, med necessity, provider admission, credentialing, drug formulary, the list goes on and on, of course, but all of those items, there should already have been those protocols in place to dictate how they should apply to mental health and substance use disorder benefits. So that's the piece that's a little bit interesting here too, is that these plans are potentially caught in a spot where they've had all of these items in place for years and years and years since the plan's been adopted, but they don't have the protocols to back it up. So in your opinion, what's different? Why is this so important now in 2022? What has changed? What has made this such a priority for the DOL, for EBSA, for states, really for plan sponsors to pay attention to urgently and immediately?
Great question. So part of it is the requirement to look at it, right? And this, my book report, but you know, really it's a provision of the CAA in the No Surprises Act section says you have to do the analysis. Well, really what they're saying is, you know, plan sponsors, you need to look at this. You need to look at your own house. And a lot of that is because I think Congress really recognized that Mental Health Parity and Addiction Equity Act has been around a long time, as you mentioned, over a decade, but plans as a whole are not very compliant with it. And I think the industry's understanding of what it requires is very different than what it actually requires. And the standards under it are pretty steep. I was reading through the regulations yesterday on this. Regulations on the mental health parity compliance itself, those are dated 2013. The actual regs after the statute was dated. So it's been a long time, but the industry has not been complying. And so I think that there was an understanding on behalf of the regulators and a real frustration around sort of the global noncompliance that led to the new requirement of taking a look at it. So all the change is now you have to look, now you have to check in on things. But now that we're looking, now we're seeing, oh, wait, maybe we were missing something all along.
And the piece about this too that is particularly troubling for sponsors of self-funded plans is that they have so many administrative requirements that they need to balance. The compliance for the new year, all the lingering COVID protocols and considerations for the workplace, working from home, maybe having those virtual desktops and the technology all put in place in it, the NSA components. What can and should they do now to make sure they are ready? Because it seems to me that the enforcement is sure, that this is not an if, this is more so a when, that everyone is focused on prioritizing ensuring access to the mental health care that is needed. I mean, this was even part of the State of the Union a couple of weeks ago about how we're connecting Americans to care and wanting to expand in the communities, and maybe potentially having this as one of the benefits that all plans are going to be required to cover, I believe it was 3 behavioral health visits every year at no cost. What should we do now?
Well, I think the first step is really looking at sort of where we are now. So there is a lot of talk about where things are going, but step one is to go ahead and actually do this analysis. And, it's not easy, the analysis. There are some deep dive questions, and we can talk about that in a little bit more detail in a few minutes. But the analysis is going to answer the questions that you are asking, Jen. So it's through that process that you find where the disconnects are. And I've looked at a lot of plans that are great plans, really well-designed plans, super rich benefits that still fail this. And they're not failing because they're not trying. They're failing because they haven't taken that deep look and realized what's going on. So it's not just me who's seeing this, right? We know the DOL came out with their report to Congress, I think it's maybe a month or so ago now. And in that report to Congress, they affirmatively said, we've looked at something like 200 plus NQTLs from different plans along the country so far, and not one of them passed. All right, so that's a scary concept. Nobody passed. Well, why didn't anybody pass? And it really was, in my opinion at least, a universal misunderstanding around how strict these rules are. And that resulted in sort of a lack of systems around making sure that they're being followed. And so my sort of global outlook on this is, as plans and plan sponsors begin to, really look under the hood on these things and do these analyses, they're going to see where the holes are. They're going to go to their vendors, they're going to go to their TPAs, they're going to say, we've got to fix this. And that's what's going to really drive the change. And if you think about it, that was really the policy objective all along. That's why Congress created the book report. They didn't create the book report because they wanted busy work for already overburdened employers. They created it to try to drive more equity in these benefit structures. And it's just that we are now all experiencing sort of the pain of those rules sort of manifesting the policy objectives.
You're right on. And the thing about this for employers is that you can't wait. You can't sit back. This is a time-intensive process. And the earlier you put together a plan, the easier it's going to be so that you could fix or address any of these issues. And instead of being reactive, maybe this is something that you're proactively looking at the plan, making the changes, reaching out to the vendor or the service provider and making sure there is a policy that you have on hand and readily available should there be a request. This seems to be something that now is the time, and if you haven't started, it's almost too late.
Well, in some ways it is too late. And I want to just be clear on this. We talk about audits, and auditing could happen, and they're going to come and they're going to look at what happened and what we did and why. This is not an audit situation. This is a situation where the law says you have to have performed this analysis. And if it's not done, you're over a year late at this point on doing it. I hate to be the bearer of bad news here, but everything is reactive at this point because this was a legal requirement for February 10th, 2021. So most health plans in this country are out of compliance with this rule at this time. The vast, vast majority of them. And so everything is reactive on one level. Now, there is the question of, oh, well, am I going to get in trouble? Am I going to be the one who gets audited relative to having done this, or the mental health parity piece underneath? And there I can say, you really don't want to be, because we've had, and Jen, you and I have worked on a number of them together, we've had the inauspicious privilege, I guess, of working on some of these audits with the DOL as of late, and the DOL is out for blood. They are not happy. They feel like they've been ignored on this point.
I'll transition us over to what's happening in the court system for this most recent United Behavioral Health case from the Ninth Circuit. And this is an example of this, where this is not only getting spotlight attention from the DOL, but also from the courts. Participants are starting to pay attention. Quick high level of the case. This was a case from, I believe, that originally settled in 2019. Plaintiffs were the participants of self-funded plans, ERISA plans, that had been administered by UBH. And they sought treatment for certain mental health or substance use disorder conditions and benefits. And that coverage had been denied by the administrator based on the internal medical necessity guidelines that had been set up by UBH. And the plaintiffs in that case argue that there was a breach of fiduciary duty, saying that the guidelines that had been determined and established by UBH were arbitrary and capricious, and they should have instead been using the generally accepted standards of care. And the district court found that that was in fact the case, and that UBH's guidelines had deviated from those generally accepted standards, and they remanded the claims for reprocessing. I think it was like 67,000 claims. But unfortunately, the Ninth Circuit came in and they reversed this order, and they held that they had misapplied the level of discretion by substituting in the court's interpretation for UBH's. So a lot of nuances, very interesting case. I recommend giving it a read. But what was your biggest takeaway from this case, Jen?
My biggest takeaway was around the conversation about the guidelines that were being applied by UBH versus the terms of the plan documents. So there's a really interesting conversation that basically said, okay, so UBH is applying UBH specific guidelines, and there was a conversation around if those were within the scope of the generally acceptable standards of care, but those guidelines don't necessarily match what's promised under the plan document. And that's, of course, something makes our hearts pitter-patter as lawyers. I always tell people the plan document is the contract. It is the contract between the employer, plan sponsor, and the participants. And everything under ERISA, all of these benefit plans, comes back to that contract. That was the piece of this that allowed the plaintiffs, this case is not over yet, and that's what's allowing this whole thing to move forward, is that disconnect.
Yeah, and this is another reason why it's super important to examine all the records and protocols and make sure that everything is matching in writing, in operation, in practice, everywhere that it might show up. So I really appreciate you joining us today and being a part of our podcast. And before we close, is there any last comment or note that you want to share?
Yeah, I do. There's one other really important point about these NQTL analyses that I think gets lost, because people say, well, what's really the likelihood that the DOL is going to ask me, Jen? Like, the DOL's, even if they have extra funding for this, it's a big country, right? You got to pick the losing lottery ticket to get audited. There's some validity to that point, but I do want folks to know that plan participants have a right to request these reports as well. And if a plan participant has a right to request it, then a plaintiff's attorney has a right to request it. And so it's not just a question of worrying about the DOL. There are sort of more likely worst case scenarios out there.
You're 100% right. The scope of request is much broader than people might think. So be prepared.
Absolutely.
Thank you again so much for being here today. And with that, we will close another episode of our Empowering Plans podcast. Thank you so much for listening.